Hello and welcome. I'm Matt Leckie, Senior Marketing Manager at Covetrus, and I'll be your host today. Today is November 12th, 2020, and we're happy to have you on our webinar titled Equine Gastroscopic Examination, Tips and Tricks to Perform Complete and Efficient Examinations, brought to you by MAI Animal Health and MDS Vet. Before we begin the presentation, just a few housekeeping notes. Our live webinar viewers are eligible to receive 1 hour of CE credit. To get CE credit, you must fill out our post-webinar survey, which will be emailed to you tomorrow. Certificates will then be sent from MAI Animal Health via email. Please allow 2 to 3 weeks for receipt. If you have questions during the webinar, you may type them into the Q&A box at the bottom of Zoom. At the end of the presentation, we'll get to as many answered as possible. First, we will start with Dr. Cherami's presentation, followed by a brief overview of scopes for the equine by Bob Battle from MDS Vet. But first, Dr. Cherami. Dr. Cherami received his Bachelor of Science in Dairy Production and Doctor of Veterinary Medicine degrees from Louisiana State University. After spending time in a mixed animal practice in Central Kentucky, he completed a large animal internship at the University of Tennessee. Dr. Cherami then completed a combined large animal surgery residency and master's degree program at Virginia Maryland Regional College of Veterinary Medicine. He became a diplomat of the American College of Veterinary Surgeons in 2000. Dr. Cherami currently serves as a senior equine professional service veterinarian. He has been involved in many veterinary associations and has previously served on the AAAP Professional Conduct and Ethics and Leadership Development Committees. Dr. Cherami is a world-renowned expert in equine gastric ulcer syndrome and has performed more than 4,000 equine gastroscopic exams. Please take it away.
All right, thank you, Matt. Just making sure that you can see my screen now.
Yep, all good.
All right, so good evening, everyone. I do, as Matt mentioned, work for BI full-time, and BI does make GastroGuard and UlcerGuard. So I just wanted to put that out there. We're not going to discuss that at all this evening. And I have some association with Bob and MAI and Covetrus just because we've partnered in the past on some gastroscopy events using their equipment. So that's my disclaimers for this evening. I do like to make a couple of acknowledgements. Dr. Frank Andrews, who is an internist at Louisiana State University, but was at UT when I did my internship there. And Dr. Andrews is the one who taught me how to do gastroscopy. And then during my residency, I got to know Mike Murray. And then when we were both at Mariel for a while, he's also helped out. And then 2 clinicians who did their residency with Mike near when I did my residency at Virginia Tech. Richard Hepburn and Ben Sykes, both considered world-renowned EGUS experts. And then particularly for this lecture, the horses that I've scoped, I still learn something and see new things, even having scoped this number of horses. So that's how we should always consider ourselves, as our patients are still our teachers. So this evening, what I want to do is just go through just a brief summary of EGUS, and the reason is to really demonstrate the necessity for getting appropriate diagnosis today, which is going to be different from even how we talked about things 10 years ago. And so recently in the Journal of Veterinary Internal Medicine, a group from the European Equine College of Equine Internal Medicine published an EGUS consensus statement. And within that, they took EGUS and made it an umbrella and talk about now 2 distinct disease processes: equine squamous gastric disease and equine glandular gastric disease. And equine squamous gastric disease is obviously affecting the squamous mucosa in the dorsal aspect of the stomach. And there's 2 conditions, primary and secondary. Primary is really associated with the intensive management of horses that have normal gastrointestinal tracts. And then secondary squamous disease is secondary to delayed gastric emptying or pyloric stenosis, related to other disease states, and basically you get GERD due to that within the stomach, and especially in folds in the esophagus. Squamous disease is very well understood and described. It's graded per the EGUS Console original publication on a 0 through 4 scale. And so we'll show those different images or images of those different grades based on size, distribution, and depth of the ulcer. Whereas glandular disease obviously is going to affect the ventral aspect of the stomach, particularly the outflow area, so the pyloric antrum and pylorus. Anatomically, the glandular mucosa is divided into 4 different locations, so we'll talk about that. It's much less well understood and described. It's not graded, but described by characteristics. And we use the location, the distribution, a subjective severity score, and the lesion type. It's also just not a disease of feeding and management. There's a lot we need to learn about this part of the disease process. And also we know that treatment is not as straightforward as squamous disease. Right? And this is going to be some numbers. It's a lot of numbers on this busy slide, and I apologize about it, but this is really the important thing. So this is just 882 cases I pulled together. 67% of these horses had EGUS. But if you look at the glandular lesions, 58% had glandular ulcers. And if we look at having only glandular ulcers, 22% had them. So more than 50% had glandular disease, and almost a quarter had only glandular disease. And so if we are not effectively, consistently getting into the pyloric antrum and observing the pyloric antrum and pylorus, we have the potential to miss the disease process going on in these horses, even in the face of having normal squamous disease, because glandular disease and squamous disease, although they occur in the same horse, their occurrence is not correlated one to the other. So diagnosis of EGUS then is really important if we're going to treat it appropriately. So gastroscopy is the gold standard for EGUS diagnosis and provides the greatest value, even though it's probably more expensive than all of these but one. It still provides the greatest value to your clients, and that's because we can differentiate the lesion location and severity, and then we can direct the most appropriate treatment for that individual horse. And I'll tell you, every horse with squamous disease, I don't treat for 28 days. Some don't need that much treatment. And so if they have mild squamous disease, it still definitely can be clinical, but you don't need to treat a full month. Or if they have glandular disease, then we know we have to look at alternative treatments, and I'll tell you, not just Gastrogard or omeprazole, in most cases, at least administered orally. Recommending follow-up gastroscopy prior to discontinuation is very important. I believe that we should do that in almost every case, but definitely every glandular disease case. Because if the client selects treatment and we don't adequately get the horse treated, then all that time and effort they put up to that point is for naught, because it's going to recur very quickly, and the horse's clinical signs will recur. Now, other diagnostics for EGUS would include a stomach block. That's a technique that I picked up from Dr. Andrews, actually evaluating colics, but have utilized that for looking at performance horses. So I do a lameness exam, basically watch them go, and if we suspect ulcers and don't find a musculoskeletal problem for their way of going, then we can attempt a stomach block, which is just passing a stomach tube, giving about a quart of Maalox and anywhere from 50 to 100 mils of 2% lidocaine without epinephrine, and then watching the horse again after a period of about 10-15 minutes, and then a little bit of lunging, putting the rider back on them, and seeing a difference. And it's amazing that some of these horses, you can actually see a significant change in the way they move. Response to therapy has been talked about, and even in the literature. The problem is you don't know where the disease is now. When we thought everything in the stomach was the same and they all responded the same, that was a lot easier, but we just don't see that. Squamous disease tends to respond very quickly to appropriate therapy. So that might tell you go ahead and scope, but not really what's going on. And, you know, if you don't have a scope, and I was guilty of this in practice, and for a period of time, we kind of even recommended this until we really learned that glandular disease is not the same as squamous disease, and they don't respond the same. If you think a horse has ulcers, just recommending a month of treatment presents the poorest value to the clients, because if you look at the data, 30 to 40% of the horses that might have clinical signs associated with ulcers don't have ulcers. So that's a wasted month of treatment for those horses. And again, if they have ulcers and they have glandular disease and all we're using is omeprazole, we may not be effective enough in treating those horses. And then the fecal occult blood test, I get asked about that all the time. There's 3 independent studies that have looked at this, at both versions of the test. And there's not enough specificity or sensitivity to really tell us what's going on, especially knowing that there's differences between the treatment effectiveness for glandular and squamous disease. So a positive test says, hey, maybe we should probably stick a scope on there. A negative test doesn't rule it out. And if the horse has clinical signs that suggest there's a problem, then stick a scope in it. There's some other things that have been looked at real quick. Hematology and chemistry, really the evidence is that it's unreliable in helping make that determination. I already talked about fecal occult blood tests. Somehow I have it on both slides, so I apologize about that. There are some serum protein markers for squamous disease that have been recently identified. That's pretty interesting, but they're not at a survey or screening situation yet with those tests. They need to do more work, and that's a recent publication out of Japan. Blood sucrose in adults, not very useful as a screening for foals, can be very useful. And then SAA in a recent study showed no association with ulcers. All right, so let's get into gastroscopy. The goal for me of gastroscopy is getting an efficient, complete examination. So appropriate equipment, adequate insufflation, and I can't repeat that enough. A systematic examination done the same every time, which will make your technique better, and then you're not going to miss anything. And then appropriate documentation. And I just have on here, I have a list of specs. I don't go through them for these talks, but I think there are some definite minimums of various different specifications of gastroscopic equipment that enables you to do a good, efficient, complete examination. And one of them is the size of the flexible endoscopic scope. And that is both in length and diameter. And in my hands, if you're going to scope 1,400-pound warm bloods, 2,200-pound Belgians, you're going to run out of scope in a lot of those horses with a 3-meter scope before you get near the antrum. I use a 3.5-meter scope, but I really think a 3.3-meter scope should be the minimum. The early studies that, if you go back and read those studies, they didn't talk often about glandular disease. It's often, if you read it, they were using 2.5-meter scopes. And so they weren't even getting near able to get into the antrum, which is actually a separate compartment that we'll look at from the fundus of the stomach. So those are some minimums. Also, the diameter, I believe, helps to get a more efficient and better exam and a better chance of getting into the antrum than using a very small diameter long scope, which also actually puts it more at risk for getting it damaged. So this is just an image of the system I use. I use a processor-based system with a 3.5-meter scope and a 22-inch monitor. And then actually I have a little desktop computer instead of a laptop. So you can see over here, it's a little desktop computer. That way I get a bigger screen than what I would get with a laptop screen. The other thing I do is I attach a suction tubing with a zip tie at the biopsy channel, and I use that for both insufflation as well as aspiration of fluid or air at the end of the procedure. So here's just looking at my case. It's divided into 2 layers. You can see the computer and screen sit on the top, and below that is the processor, suction unit, and a little box with all the cables and everything else I might need there. And then I have the scope suitcase. So as far as sedation, my preference is romifidine, and that was long before I went to work for BI. I find that you get the horse to stand much better. They're less ataxic. They don't drop their head as much, and they maintain a much better swallow reflex for swallowing the scope, which again limits the potential for getting it bit. Since that has not been available for a while, I use a combination of xylazine and ditomidine. And I like the combination because I can use lower doses of each than I would use individually. And I get less of the side effects, but adequate sedation. Where I put these horses in, ideally, is a 3-sided area, like a wash rack with a rubber floor or a tacking area, the corner of a large stall or an open exam area. The end of a barn aisle with the door closed at the end to create that 3-sided area. And then stocks, that's just a personal preference, is last. When a horse is in stocks, people tend not to pay attention to the horse until wrecks happen, and I've seen them happen. Horses tend to lean on the gate, especially if the gate for the head is high, which will put pressure on the esophagus and make it a little more difficult to pass. I don't usually use lube at all, and I like to have suction all the time with me. The goal of getting a exam done is, again, like I said, efficient and complete, with safety for the horse and the people and safety for the scope. And so the technique that I've developed over the years, some of it was taught to me by Dr. Andrews, and a few other things I've come to determine over years myself. I will say if you follow that technique, you cannot get a scope bit. And I show this picture of a scope. I was present for this scope to get bit, but I wasn't involved with the passing of it. And you can see it got bit at the 130 centimeter mark, so not the tip. And with these flexible scopes, even the large diameter scopes, because there's not very many fiber optic fibers anymore in there to make it rigid, it's just a wire and a few fiber optics for the light. And some of them actually have lights at the end, so there's no fiber optics in them. They are very flexible. And so they can S-curve even these large diameter scopes with the tip of the scope in the stomach. Okay, so the technique is having a passer who should not be the veterinarian. The veterinarian should be the driver, and then a horse handler. And the technique is for the passer to watch the screen, and the screen is going to be set up in a way that they don't have to turn over their shoulder to see it, until the scope is passed almost to touching the arytenoids. At that point, they're going to drop their hand 10 centimeters on the scope. I'll have some pictures to show you that. They turn and look at the throat latch, and then they gently push the scope to the back of the throat and wait for the horse to swallow and advance it as the horse swallows while they're watching the swallow. And then the driver is actually manipulating the scope to instill a little bit of water and some air to help encourage the swallow. Once they pass the scope, when their hand hits the nares, they stop. And then 100% by visual examination is confirmed that we're in the esophagus. When we pass the scope and the horse swallows, the scope can go one of 4 places: into the esophagus, into the trachea, retroflex into the nasopharynx, or retroflex in the oropharynx. And if you only pass it 10 centimeters, because of the bend in the scope, you're not going to pass 10 centimeters back cranially around the caudal edge of the soft palate. So you can't get far enough to get between the teeth. I've seen the back of a lot of tongue bullet, and I've seen teeth in the background. And you just pull the scope back out and attempt to swallow again. And I'll tell you, if you do this technique, which is, I've done more than 90% of the horses I've scoped with this technique now. And until 2 years ago, I had never got a scope bit. And we got a scope bit on the tip when I was scoping at a day on horse 17. So it's not like we didn't know what we were doing. The technician had been passing the scope for 17 horses that day. And we quit paying attention to our technique. And the technician passed the scope, re-grabbed and shoved it back in. And I was kind of just looking, saying, wow, look, those are teeth. Holy cow, those are teeth. Well, now I don't see anything. And so we did not follow the technique. And so here is how I set up. You can see the system is facing opposite the passer. So the passer stands on the side of the horse's head, passes up the nose. I have them pass with their primary handedness. So if they're right-handed, they stand on the right side of the horse. If they're left-handed, they stand on the left side of the horse. I stand a little bit to the side of the horse, so not directly in front of them, and we're watching the screen. The handler ideally is watching the horse because we're not paying attention to the sedated horse. Okay? So here is the passer with the hand drop 10 centimeters. Okay, so we can see a little bit here on this side of the 50, and then about 7 more centimeters here. And then when the horse is going to swallow, the passer turns and watches the throat latch and feels for the swallow, not the screen, because it's going to go black or pink, or there's going to be some delay in some of the systems. There's a little bit of delay. And then when they pass it, their hand hits the nares and they stop. And then the driver, the veterinarian, confirms 100% that we're in the esophagus. And then I insufflate while I'm passing the scope to the esophagus. And that point, the passer turns and looks at the screen. And every time they push the scope in, the passer's job then is to make sure that the scope advances along the tissue. Or if not, when we're in the stomach and in the greater curvature, that they can see the scope coming into the stomach through the cardiac sphincter. Okay, so they need to be assured that they see advancement of the scope and that it's not S-curving in the pharynx. When I get to the stomach, I make sure that it's adequately distended. We'll show some pictures of that. And then I do a very systematic examination of the glandular fundus. Then we get into the pyloric antrum, the pylorus, the duodenum. We pull the scope back in, pass it halfway around the stomach and get a direct view of the lesser curvature. Then we pull the scope back with it retroflexed on itself to get a close-up view of the lesser curvature. And then we work our way around, starting on the left wall through the greater curvature, coming back to the right wall, and then looking dorsally. And then we rinse as needed, document with video or still images, take the air out, and then we evaluate the esophagus on the way out of the stomach. Don't worry about it going in, just get to the stomach. And being in the horse's stomach should be about a 7 to 10 minute procedure. In a lot of the situations, I have owners around and we have to discuss at that time because as soon as I pull the scope out of one horse, we're going to be starting another horse. But I would recommend that you do the exam, take your pictures, and then if the owner's present, once you're finished the exam, discuss it, pull up the pictures that are relevant and have a discussion at that point. And you minimize the time that you're in the exam. There's not a lot of potential complications. There's a recent study that looked at that and they saw colic in some horses, but actually there was a group of horses that got scoped because they had gastric impactions and were colicking. And after the exam, they were colicky, but they had gastric impactions and had been presented for colic. So if they took those horses out, it was a very few number, less than 10 instances of colic in over 200 exams. And maybe even more. I need to get that number. I apologize. So I see a very low incidence of any complications of the procedure, but the longer you're in, that's when we tend to see, I think these things potentially develop as we keep these horses really distended, because adequate distension is really the key to getting that good, efficient exam. Understanding the anatomy of the horse's stomach is the second one. So if you look at a picture of a horse's stomach in an anatomy book, it's not going to look like this. But this is a picture that was done from taking some in situ pictures of some distended stomachs, as well as pulling the stomach out, emptying it, distending it with air, and then taking pictures and having some anatomists draw these pictures for me. And this is what the stomach will look like when it's distended, and this is going to be our visualization or our view of the stomach as we go forward. So the esophagus and the antrum are both on the cranial aspect of the stomach, and the antrum is not ventral. And so there's the squamous fundus, the margo plicatus, which divides the squamous and glandular tissue. The cardia of the glandular mucosa, the horse's stomach does have two cardias, unfortunately, is the first kind of 2 centimeters or so distal to the margo plicatus. The glandular fundus, the antrum, and the pylorus, or the pyloric antrum. Don't call this area the pylorus, because again, if we're scoping a horse and then it's going to go somewhere else, and you write out there was ulcers at the pylorus and it comes to me, I'm going to think the ulcers were here. And if they were here, I'm going to think that's different ulcers that have come up while there was treatment. So in that paper, it really says we should all talk about the stomach in the same way. And then also looking at the anatomy of the stomach, this is a view of a three-dimensional rendering of a stomach from the dorsal aspect. And you can see that the esophagus comes into the right side. And so to make a curve so that the scope can go around and come back cranially, because you can't just turn it down and then go into the antrum. It doesn't happen that way. We have to pass it into the stomach and use the curve of the stomach to guide the scope. It's not going to go where you point the tip or look at the screen. It's going to follow the curve of the stomach. And so if we understand that curve, we bring the scope in from the right, along the right wall, through an adequate curve, because we have adequate distension, through the greater curvature along the left wall into the antrum, and then through the pylorus into the duodenum. And visualizing that in your mind, I think really helps with understanding what the scope is doing. And so here's our picture version of that. This is just passing the scope in. So looking ventrally, this is the left wall here, the right wall here, the lesser curvature. I insufflate until all the glandular or all the squamous rugal folds are definitely gone. And most of the glandular rugal folds, particularly on the left wall, are gone, because that's where you're going to get hung up as the scope comes around. So we're going to start, we're going to start that process going along the right wall into the greater curvature. As I get into the greater curvature, the passer is going to feel resistance. So I turn the scope back so they can see the scope being pushed in. Right? Because if it's not moving along the tissue, we tell them don't push anymore. So we turn the scope back so they can see the numbers and the lines. And eventually when you create enough compression along the right wall, the scope's then going to start moving forward. You'll have to straighten it out, aiming for this area here, the lesser curvature left wall junction. Sorry about that. And the scope's going to keep moving forward. As we move forward, the scope does drop a little bit because of gravity, and you get along the left wall. So we pass the scope along the left wall. You can see there's adequate distension because the antrum is this cavity in the background there. So we keep moving in right near the lesser curvature. I always kind of take a look here so you can look up to see this, because from the fundus, you may not see some of these lesions if they're rolled under. So it's a good opportunity to take any pictures and look in this area. Get in to the antrum, evaluate the antrum, note any lesions, and then work your way up close to the pylorus, and then through the pylorus into the duodenum. I don't spend much time in here. I basically want to see 360 degrees of the circumference, make sure I don't see any lesions. I don't put any air in the esophagus, and then I pull right out. Here you can see a greater papilla of the common bile duct with some bile in the background. If there's a lesion, I do biopsy these, because that's really going to help dictate the therapy. And I've been able to really help a lot of horses that had duodenal lesions beyond their gastric disease. And if we don't treat their duodenal lesions, I don't think they occur together. So it's separate diseases. We're talking generally about granulomatous, eosinophilic, plasmacytic, lymphocytic, lymphocytic granulomatous type diseases that are normally responsive, very responsive to steroids. Then we pull all the way back into the fundus and we get this view again. And then this is where we're going to start our examination of the squamous mucosa. Okay, so I start looking at the lesser curvature, particularly the right wall lesser curvature junction, because it's the most ventral. And I don't put any fluid in here unless I need to rinse a little bit of the antrum, but I minimize it. And I definitely don't rinse until I evaluate this area, because if you start rinsing and see, oh, look, there's a big lesion on the greater curvature, and you start rinsing, you can put enough fluid in here that you're going to hide some lesions here, and we don't want to do that. So this is the area I want to start with. And then once I evaluate this area, we rinse it if we need to, then I get a good view of it. And what I'll do then is at this point, I pull the scope back or have the passer, but continuing to look at this. So I get a nice up close view of that lesser curvature. And then I start by turning the wheels, manipulating the scope tip to look at the left wall lesser curvature junction. And then I move that exam systematically along the left wall, rinsing as I need to, coming around. So here's the lesser curvature up here, moving across the left wall, coming into the greater curvature, rinsing as we go along, see, uncovering lesions. And then in this particular horse, the next view, we uncover additional lesions as we rinse and keep pulling the scope back to look at the right wall. Eventually we get to the cardia and I look straight down, visualizing those, the lesser curvature. If there's lesions, you can get another up close view from a different perspective. And then I'll pan the scope kind of across the floor, up the greater curvature along the flat caudal wall, and then look at the dorsal saccus cecus. And then we've completed a complete examination of the horse's stomach. I'll remove the air and pull the scope out and evaluate the esophagus on the way back. So here is the squamous ulcer grading scale. 0 is normal, 1 is mild gastritis, no ulceration. So the mucosa is intact. It might be thin, but it's intact. And if it's thin, that's where you're going to see hyperemia for squamous disease. Or if you see hyperkeratosis, that's going to get dumped into a grade 1 as well. So the first ulcers we're going to see where there's actually full thickness defects are grade 2. And grade 2 are generally mild, small, single or multifocal ulcers. Whereas grade 3, then we move into large, single or multifocal lesions or extensive superficial lesions. And then grade 4 are very severe ulcers, extensive lesions, often with areas of deep ulceration. I'm going to run through these very quick because I want to make sure we leave some time for Bob and questions. And I want to show you the glandular disease pictures. So normal, there's a little bit hyperemia with some hyperkeratosis, a little bit of mild hyperkeratosis here in the lesser curvature. Here's a little island of glandular mucosa within squamous disease. So this is not an ulcer. I get some of these sent to me and saying, I treated the horse for 4 months and it hasn't healed these ulcers. And that's never going to heal because that's normal glandular tissue that is surrounded by squamous disease, or squamous mucosa. And you just have to look at it real close and be able to determine that the edge of the squamous lining is normal, and then that's glandular mucosa and not a wound bed. It takes a little practice, but they do have that as a normal finding. And then you can see some fairly significant hyperkeratosis, but again, no ulceration in this horse. Mild grade 1 lesions, different appearances. Here's a grade 3. We got a large single lesion. It's the most diameter of the scope with some mild ulceration in this area. Here's another grade 3 because we're getting extensive, superficial, beginning to coalesce to more moderate size ulcers. A single, again, single large ulcer, squamous ulcer with some smaller ulcers, again, as a grade 3. And then grade 4, extensive, large, deep ulcers all around. Here's another example of that. These just very large, very deep ulceration that dump it into grade 4. I have on here possibility of rupture. I don't think in adult horses they rupture on their own. I have seen a horse that had colic, probably for a secondary reason because it was obstructed. It got a reflux, but it ended up rupturing. And when it was evaluated at necropsy, there were some ulcerations that were fairly deep, and part of the rupture went through that. I think that's very, very rare. However, it's a more common occurrence in foals. So that always be cognizant of that, that foals are much more likely to potentially rupture than adult horses. And then again, a dorsal ulceration in this horse. Got to look everywhere. Some of the things that we might find that kind of are normal is called desquamation. So we have some normal squamous mucosa here in this picture on the right under the scope. You kind of see this brown area, and this darker area is where it's folded over after I rinsed and hit it with the water, and then it's kind of missing here. And underneath it is normal. So that's kind of a normal process we see. It may also be something kind of like think of it as a sunburn that's peeling, and then the tissue underneath is normal. So maybe there was some very mild chemical burning from the acid, and it's peeling off, but the underlying tissue is normal. I do not treat these. And here's a little more in the graded curvature. It kind of looks a little more wrinkled here, and when you hit it with the water, you can actually see the edge of it raise up, but the tissue underneath it is normal. It tells me that the horse may be getting some heartburn, so we treat the intermittent heartburn, but I don't in and of itself treat desquamation. And then, like I said, the glandular ulcers are going to be characterized on different properties, not given a score, because when you see them, you'll see that it's really not something that we can do. So location: cardia, fundus, antrum, pylorus. I know the duodenum's not in the stomach, but I always put that on there because I do want to get in there. It's my goal. I don't have a complete exam in my mind until I get into the duodenum. So it's going to be there as well if I note lesions. And then the distribution, whether it's focal, multifocal, or diffuse, and a subjective severity scale of mild, moderate, severe. And then we characterize the lesions as one of 6 different types. And those are flat, hemorrhagic, or hyperemic, but with erosion. If the tissue is normal and the tissue is just hyperemic, I don't treat those. I don't know what to do with them. Are they a pre-lesion? We don't know enough about that. But I treat what I see as abnormalities, and I can't say that hyperemia is something that's going to respond specifically to our therapy, because all of our therapies are directed specifically at the mucosal membrane. And if it's intact, then I don't know what to do for hyperemia. Flat fibrinosuppurative, raised hemorrhagic, or raised fibrinosuppurative, depressed plus or minus a blood clot, and depressed and fibrinosuppurative. And so here we go. Here's the pictures. Flat, hyperemic, hemorrhagic, meaning that the tissue flattens out, and you might have hyperemia with erosion, or you see hemorrhage on the surface. So we know there's a defect in the mucosal surface. Flat and fibrinosuppurative. So we see these kind of fibrin or purulent type of plaques. Again, they're flat. They may have a little bit of petechiation or ecchymosis within them, but we're going to kind of call these all flat fibrinosuppurative. Then we get raised hyperemic, erosive, or hemorrhagic lesions, meaning that the lesion does not flatten out. Now here's a rugal fold that's normal. This would flatten out, but this area did not. So that's related generally to either hyperplasia of the gastric glands or fibrosis, response to that abnormal process that's going on there, which we really truly don't understand. And that's what we covered in the last lecture. And so you can see different versions of these that we see. Then we get raised fibrinosuppurative lesions. Again, the rugal thickening there. Oftentimes they'll appear kind of like these polyploid masses, but they can be along rugal folds and extend for quite a ways. Again, so all these are antral. If they're going to be pylorus, they need to involve the pyloric ring and no more than 1 centimeter out of the ring. If they're here, that's an antral lesion. You noted that it's very close to the pylorus, but in my opinion, the pylorus is the ring itself and 1 centimeter into the lining of the antrum. And then these, we do actually see some depressed lesions. Most of the lesions are going to be erosions, and they're not true ulcers, because an ulcer is a medical term referring to a defect down to the lamina propria, and these don't go all the way to the lamina propria. in the vast majority of them. But you can see here's a defect with blood clot. Here's a defect that looks like you took a bite out of that with a biopsy, but it wasn't biopsied. Here's a little defect. And this is a bute toxicity case. On this area, it actually was a significant defect in the tissue. And then the last one is depressed, but a fibrinosuppurative lesion over it. So if you see some fibrin or purulent materials, exudate sitting there, you really need to hit that with your water wash or rinse and see if there is a lesion under that. Now, I don't know what happened to the picture that I took after it, but somehow I've lost it. But when we moved this, there was a small little defect there. And then some lesions like this horse with, again, bute toxicity, which tends to involve the pyloric ring as the primary location, can be multiple lesion types. So we have some raised fibrinosuppurative lesions here with some petechiation and some flat hemorrhagic lesions over on the opposite side. Things you might see, some bots. I don't treat that level of bots. It's not hurting the horse. Excess treatment just leads to resistance. This lesion, nest of them, I will treat. I have started to see stomach worms again, but only geographically in Texas, the West Coast, and one case in North Carolina. Most of the time, we don't see lesions associated with them. You might see some nodules for Drasha, but every once in a while, we'll see some lesions. So here, and they typically occur at the left wall lesser curvature junction or the right wall lesser curvature junction. And you can see here, they were actually creating some inflammation. So we treated those. And then as a GWiz, it's the only time I've ever seen it, but if you stick the scope in a duodenum and you see one of these, that's an ascarid or a roundworm. I've seen it in foals, I should say, more frequently. This is the only time I've seen it in an adult horse. Incomplete emptying, but don't give up. You can potentially get your scope down if you come around it into the antrum. And so that can be beneficial to kind of help guide how you need to go with there. But a horse like this, you're not going to get that scope into the antrum. Phytobezar, you can see the mineralization. Don't rub your scope up against it because that'll scratch your lens. Pull out and give that horse 2 liters of Diet Coke and do that 2 days apart and come back in a week and most of them are gone. Duodenum, normal duodenum, a couple Brunner's glands in the duodenal diverticulum. And then you can see lesser papillae, greater papillae of the common bile duct. There's some bile being squirted out. Petechiation, so this is abnormal. I would biopsy this horse. This horse we biopsied, it had plasmacytic, lymphocytic infiltration responsive to steroids. And then this horse actually biopsied, and here's post-biopsy. And this horse was an eosinophilic granulomatous enteritis that responded to steroids as well. How to do biopsy? I don't biopsy glandular mucosa much anymore because it doesn't help determine whether or how to treat. If I think neoplasia is a potential, I will biopsy there. A double bite at least technique. So get a bite and then try to get in the same exact hole and get a second bite so you actually get adequate deep tissue. So it's going to look like that when you're done. Esophagus pull out, it stretches out in front of you on the way out. You've already decompressed. Don't put a bunch of air back in if you don't have to. These are some of the lesions we see. Most of these are looking at primarily at esophagoscopy. I will see lesions like this in foals that have secondary EGUS because they do get reflux into their esophagus, but it's rare that I've ever seen an adult horse with acid lesions in their esophagus. And then don't forget on the way in to look at the pharynx. These are, I have on here, incidental findings until we started talking to the owners, and each of these represent an issue that was determined just from questioning the owners. We could say, okay, these are not incidental, they're actually clinically relevant. So hemiplegia, epiglottic ulcers, epiglottic entrapment, subepiglottic cyst and subepiglottic ulcers, another entrapped epiglottis with a ulceration, so you know it's been going on a long time. Bilateral retinoid chondritis, again, all were clinical when after speaking to the client. I'm not going to take questions right now because we're going to let Bob go, but I did want to put my contact information if you want to screenshot or write that down, my email, my cell phone. If anybody ever has any questions, don't hesitate to contact me. And then there's a couple really good videos that we've done a few years ago that live on the gastriguard.com website. It's a how to scope video. It's about 25 minutes long. It talks about equipment on the front end, then it goes through that exact procedure in a very demonstrable way, showing video from the outside of the process, video from the scope. Oftentimes when we get to that point, it's side by side, and it covers really everything that we talked about tonight in a very good format. Except the only thing I do is I changed how I do the exam. You'll notice that. So the first part of the squamous exam is to pass the scope back in and look directly at the lesser curvature so you don't raise the fluid level. And in the videos, that's kind of at the end of the squamous examination. So I've changed that around a bit. But I'm going to stop sharing and turn it over to Bob.
Yeah, that was very insightful, Doctor. Thank you, Dr. Jeremy. So yeah, we'll go ahead and turn over to Bob. So Bob, if you want to go ahead and share your screen or your live video. And then while we're waiting for that, if anyone has any questions, if you go ahead and type those into the Q&A box, we will answer those at the end of the presentation. If we do not have time, we will follow up with the answers via email. All right, Bob, take it away.
How's that? Can you see me there?
Yep.
Okay, so Hoyt, thank you for all that information. Great information. It's a pleasure working with you, and pleasure working with you, Matt. Just wanted to go over basically the scopes. I'm not going to show any videos or anything like that because Hoyt covered that already. A lot of those images.
Hey, Bob, we're seeing your screen right now, not your live video. Like,
how's that?
Still waiting on it.
Okay, hold on. Well, share.
Bob, if you hit start video and stop sharing your screen.
Stop sharing my screen and start video. How about that?
That's good. We see you. I see you.
You got it? Good to go?
Yes.
Okay. All right. So here we go. The 3.5 meter scope that Hoyt's talking about. This is the system right here. I got a couple of different scenarios set up here, so you can have your video scope, the 3.5 meter scope, with your processor, and this is the only thing basically that you need to go out and do your examination. You've got your laptop here, which we include the software that you need to record any video or pictures for that. We also have the portable screen. If you don't have a laptop available, you can put the portable screen on here. It's a smaller picture, but for whatever reason, if you need that, you've got that. But the important thing is the 3.5 meter length and the 12.9 millimeter diameter. That gives you the rigidity of the scope to get it pushed to where you need to go and gives you the length to get there. The way I've got set up here is in a clinical situation with a laptop computer with a cart. If you've got a cart, fine, and we'll put everything on your cart. If you don't have a cart, we can get you set up with that. The other way is completely mobile. You're out and about, got a large case that you can put your processor, your suction machine, everything in there and run everything from your laptop computer. That tends to be the most popular setup that we do. Suction, as Hoyt was saying, very important. Our suction machine has a 1,500 millimeter canister that less emptying, a lot more capacity there. This particular unit has a battery on board, so you can actually move it around without having to have an extra place to plug it in. So this has got a battery on board. The other setup is for in clinic. When you've got a monitor already, any medical monitor will plug right into your monitor. The processor itself has DVI output, which will go to HDMI. It has a YC output, which goes into the old BNC connector. And it's also got a USB output to go into your computer. So any particular any particular monitor you already have set up, we're ready to go with any configuration you have set up to go. We have not only the 3.5 meter scope for gastroscopy, but we also have the upper airway scope. The upper airway scope is a 9.2 millimeter diameter with a 2 millimeter working channel. Same processor, so you just unplug one scope, plug it into the same processor, you're ready to go. And then we also have the completely portable unit. So this is a 9.2 millimeter as well, with the 2.8 millimeter working channel, portable light source, LED light source. So everything's on the screen here. You white balance the image here, and you've got everything on the screen, completely portable. You can go stall to stall. It's a separate scope from these two systems because this has everything included all in one place. But we have just a very versatile system as far as that goes. MDS Vet, just in case you've never heard of us, we've been around since 1972 in the vet market, and we've done nothing but develop unique and affordable equipment for veterinarians. So this equipment is not what you think of as in price wise as what used to be. This is very affordable even for the solo practitioner. We have service in 2 different locations. We have it in Florida and also in Wisconsin. We can do a complete rebuild of any of this equipment from start to finish. Even if you do get one of those unfortunate accidents where a horse might bite through the scope, if you have any kind of insurance on your equipment, you've got that pretty much covered. I don't think I've ever had one of those repairs turned down by an insurance company. So that's always a good thing. Our scopes now, especially these 2 scopes with the processors, are HD now. We just recently switched over to an HD system. So we've gone from 440,000 pixels to 770,000 pixels on the image, on the image sensor, and these scopes now, all of the scopes are camera in the tip of the scope, called chip on the tip. No more eyepiece to look through, no more broken fibers. It's a much more diagnostic system. And as you can see from the image quality, that it's a much better quality than you used to get with any of the fiber scopes that you used to have that had the old screen door effect. You never get that anymore with our scopes. The 770,000 pixels is considered a true HD image. So any of the instruments that you need to go with the scope, biopsy instruments, guttural pouch probes, any of that equipment is also available with us. And being in the business since 1972, we feel like we've got a pretty good handle. And BI has been a really good partner in all of this. And any questions for any of this equipment, I'd be happy to take any of those now. Or if you have any for Dr. Jeremy, let's go ahead and start the question and answer session.
Great. Thanks, Bob. So we have a couple of questions. One that came in was, if your horse doesn't empty its stomach, does that indicate delayed gastric emptying?
Yeah, so I showed a couple pictures of the stomachs that weren't quite empty. And in my mind, it doesn't automatically mean that the horse has delayed gastric emptying as a primary problem. In fact, it's probably highly uncommon. The horses don't empty for various reasons. One of them is that the preparation was not adequate. And when I learned how to do gastroscopy, we used to pull the horses or put them in PO 12 hours out. And I found when I was able to then make those determinations on my own and decisions on my own on scoping in practice, was that if I did that, the horses tend to be fed and then allowed to eat a bunch of hay and then everything pulled, and they didn't drink for the overnight. The hay just desiccated in the stomach and it didn't leave. Horses don't produce a lot of saliva unless they're chewing. So I leave water with them until 2 hours prior to the exam, and I withhold any food for 14 to 16 hours. And we still every once in a while get a horse that has some feed material left, but more than 95% of the time we can get a good, complete endoscopic exam.
Great. This one's probably more tailored to Bob. So, Bob, can you talk about kind of the pros and cons of LED versus like a xenon light source?
Yes, and there's two ways you can deliver LED light to the stomach of a horse, which is when it's fully insufflated, fully distended, you're gonna have a large space inside that stomach. LED lights at the tip of the scope generally are 5-watt LEDs. They're not very diagnostic. They don't tend to be a sufficient amount of light to be diagnostic. What we do with our LED light here is take 24 watts of LED light and pump it through the scope, through fiber optics. That's the only fiber optics left in these video scopes is the light carrying fiber optics. And that tends to give a much more diagnostic view and a much better image on the scope. We do on the portable upper airway scope, we do use an LED light, but it's a light source attached to the scope, not lights at the tip of the scope. Be careful about those lights at the distal tip of the scope because they're generally those tiny little 5-watt LEDs, and they're not very light producing and therefore not very diagnostic.
Okay. The next one probably here for Dr. Sheremy. So how do you refeed the horse after the gastroscopy? So
refeeding is quite simple. Always wait until the horse is not sedated anymore. I have seen cases where the sedated horse gets given food and it's just after any sedation, obviously, and then they choke. And then so you actually end up taking your scope back out and undoing a choke. My preference would be to, once they're awake, is to allow them to graze since there's a lot of water in the grass. If you offer them water and food, they tend to go to the food first because they're starving, right? Or they think they are. And they can eat fairly quickly. So that's another thing just to watch. So if I'm not going to be able to graze them, I offer them water. And then after at least of about 15 minutes of just having access to water, then we can offer some roughage. If I scope them in the morning, they don't get their morning concentrate meal. They'll just get fed in the evening as normal. If I scope them in the afternoon, then they'll just get roughage through the rest of the evening and concentrate the next morning.
Probably have time for one final one. So for Bob, so what would a kind of a system cost? Like a rough ballpark to get set up and going?
Okay, so the 3.5 meter system with the processor, using your own laptop, doesn't have to be a special laptop, can be anything off the shelf pretty much with our software that's included. You're looking at about $15,300, so $15,300. That's suggested retail. Through your distributor, it might be even a little better deal. They usually will cut you a better deal through distribution. An upper airway scope to add to that existing system is going to be about another $10,000. And then if you want the standalone portable upper airway system, that's about a $13,000 system. The suction unit that we sell, which has been real popular, is about $600.
Great. So I think that's probably all the time for questions we have. So I would like to thank Dr. Sheremy. Oh, sorry.
Hey, Matt, let me, there's one that I can see that popped up just about the stomach blocks real quick. It looks like we have a minute left. So I apologize if I go a little bit over, but I
go ahead.
That one that I see that popped up. So the stomach block I use, again, it's during a written exam and the technique is unsedated, pass a stomach tube, usually not a large bore. I'll try to pass a small bore stomach tube. And then I will give the horse a quart of Maalox and 50 to 100 mils, so a half to a full 100 ml bottle of lidocaine at 2% lidocaine without no epinephrine. I don't want to give a horse that much epinephrine at once. So the lidocaine without epinephrine, which most of us are using. And then I'll let the horse sit for about 10, 15 minutes, jog him on the lunge line for a few times in each direction, and then put the rider back on them and watch the horse go again. If you had attended the EGUS session, or if you want to ask me about why I think doing that and getting rid of stomach pain changes how a horse moves, there's a couple of nice studies that actually support that. And my clinical experience is that you can see in a lot of these horses a change in their way of going, because gastric pain as a reflex creates an abdominal muscle girdle contraction. And so that actually kind of overflexes the axial skeleton. And so it changes how the horse can move and appear during movement.
Great. So thank you very much. So any questions that did not get answered, we will forward those to Dr. Shermy, who will get those answered via email. Thank you everyone for your time tonight. Again, you will receive a survey emailed to you tomorrow if you could complete that in order to receive your CE credit. Have a great night. Thank you.
Thank you.
Bye.